So welcome everybody to our next presentation in our COVID-19 series. We want to welcome Hartford Healthcare, and they're going to be presenting tonight digital transformation and optimized clinical workflows to support COVID-19 rapid response. Okay. We want to make sure that you're aware that this program is presented to you through a joint provider agreement with Hartford Healthcare and NENIC, but it is also, we have a joint provider agreement with Boston Children's Hospital, and they help us get our CEUs. So we are so thrilled to have partnered with all these wonderful organizations to help inform and educate the informatics community. I have, the speakers have no conflicts of interest to disclose, and there's no commercial support for this program. I'd like to take a minute and introduce all our speakers, which we're just thrilled to have. Sue Marino, who's the VP and CNIO of Informatics at Hartford Healthcare. And I reached out to Sue. I think she was on her way to vacation, and she was very nice, one, to take my call, and second of all, to agree. So,
I was in a happy mode at that moment.
She was very happy. So always invite somebody to speak when they're going on vacation. Linda Ruggiero, who's the System Director of Informatics at Hartford Healthcare. Dianna, who's the System Director of Informatics at Hartford Healthcare. And Michelle Schneider, who's Analytics Clinical Lead for Informatics at Hartford Healthcare. And I would like to welcome everybody and welcome to this exciting program.
Very good. Well, thank you, everyone, and Mary, certainly for inviting us. This is a great privilege. And so I'd just like to go through our program today. So a few remarks from myself, but the important stars of this program today, certainly Dianna, who will be speaking about colleague redeployment. I'm sure that we all went through something similarly in each one of our organizations. Linda Ruggiero will be speaking on the topic of personal protective equipment and a program that they implemented in our Fairfield facility, St. Vincent's Medical Center. And then Michelle will be addressing analytics, everything analytics, a fabulous program that she had a tremendous amount of responsibility throughout all of our COVID and even through today with our program. So our objectives, describing the colleague redeployment, discussing St. Vincent's Medical Center and their innovative PPE management and approach for the surge process, and describing how Hartford Healthcare Informatics successfully supported the COVID response with clinical data visualization. So a little bit more about Hartford Healthcare. We have grown, as many of our organizations have these days, healthcare organizations, tremendously over the last 8 years. We now have 7 hospitals. Most recently, again, our St. Vincent's location in Fairfield region, and Linda will speak a little bit about a little bit more of the challenges we had in that region as they bump up against our friends from New York. But again, not only our acute spaces, but a surge in urgent care centers, imaging locations, medical groups, you know, our cancer centers. It's just been an amazing journey over the last 8-10 years in really not only with things like our EMRs, but just the from our purpose and our team being able to support all these different domains. Many of us came from the acute space and now are supporting all types of post-acute, all of our ambulatory, our care management services, you name it. We've gotten into just about everything, and it's been quite a trip. So I thought I would spend just a moment talking a little bit about, actually I'm gonna go back to my last slide. I don't wanna give that away. About our initial journey. I know that so many of us had just an incredible liftoff back the end of February, beginning of March. and went into this frenzy of work. And at some level, it hasn't ended. We felt like we've come out, but we're still working at an extraordinary new level. But what we managed during the first 3 months, 4 months was just impossible to even believe what we were able to accomplish as an organization and as a team, and what we were supported. It started for us in what we call our Care Logistics Center. That is a remote area that manages every one of our beds and moves patients throughout our organization. And on the first days of our COVID movement, that became not only our bed flow area, but also our triage and call center for everything COVID. We helped to set up all types of lines, got staffing in to manage the lines that would not only give patient a place to call, but could also access centralized appointments. It became the beginnings of setting up all of our virtual health network, which exploded from about 200 virtual visits a month to we're closing in on about 300,000 virtual visit, which in 4 months was just an extraordinary pathway. We helped set up drive-through testing centers. We did primary specialty care and all types of movement of all those staff. We did an amazing amount of our EMR revisions, making sure that patient banners, making sure all of our infectious disease components, you name it, clinical decision support, best practice alerts, documentation, just on and on and on inside the EMR, our lab services, and third-party systems. So a tremendous amount of work. But what we tried to determine when we got ready to put this program together was we wanted to try and look at some of the things that we really felt were special to us. We knew that there had been an individual NENIC presentation on virtual health, so we decided to not go through that program with you. But we're excited about the 3 that are coming up. But I wanted to just add one more thing to the program, and unfortunately, we're all starting to replan for the potential for what's coming. And I thought I'd just take a minute, step back, and just go over some thoughts with you about 10 things that you'll need to get through if the second wave comes. And so just with a little bit of levity, after all we've been through, here are some things that we're thinking about, and I just wanted to share with you. So let's all make sure we have our exercise equipment. I don't know about the rest of you, but I'm still not exactly where I need to be from pre-COVID weight. We should all get a humidifier. There is evidence about humidity, relative humidity within your homes and spaces that will support your health. Certainly air purifiers, a pulse oximeter for those that need some support from a respiratory perspective. Thermometers, let's get rid of the ones we got right at the beginning of COVID, and let's go get a good one, because the ones we have probably are less than effective. The one that really kind of made me think a little bit, but it was right out there. Apparently the bidet toilet seats are a hot item, and will be as we move in and thinking about saving toilet paper. And certainly house plants will keep you mentally on a stable ground. Look for your baking supplies, especially those as we head into the holidays. Don't forget COVID supplies, and certainly with the potential for the twindemic heading toward us, flu season supplies. So, and last but not least, let's help each other get through the next wave, should that come our way, and let's do it together. Let's make sure we all get our flu shots. And on that note, I would like to introduce Dianna Corrali, who's going to help you understand our challenges with staff redeployment.
So good evening, everyone, and thank you for the opportunity to address NENIC this evening and to talk about some of our initiatives through the COVID-19 pandemic. We had a stream of COVID-19 positive inpatient admissions that was rapidly increasing. You can see the numbers as of 9/24/2020 from all of our hospitals and Hartford Healthcare that are on the screen right now. Our critical care areas needed additional staff to care for the patients because many of the COVID-19 admissions were critically ill and on ventilators. There was rapid deterioration of the patients in the early weeks, and as we all know, the plans of care were changing as the different treatment modalities became more aware. We developed proning teams, and they were created to turn the patients to improve respiratory capacity in those teams. Usually we're about 4 to 6 people, so we needed to really have a lot of people to be able to do that around the hospitals. Additional surge areas were opened at all of our acute care facilities, increasing the capacity for the bedded patients. Our ambulatory clinics closed, and our surgical volumes dropped dramatically. So when was the staff redeployed? It really, around mid-March is when we started to see that we really needed more staff because we just couldn't care for the capacity that we had with the staff that we had normally. They were deployed to critical care areas and any other area of need. Nursing assisted respiratory therapy for treatments because very quickly we didn't have enough respiratory therapy staff to do the job. Testing sites were developed and they entered orders, they performed tests, and they called patients back with results. Screening stations for staff and visitors to make sure that they didn't have fevers, and we asked the travel screening questions to make sure that we kept our patients safe and our staff safe. They developed a regional operational command centers that we affectionately called our ROC for staffing. And surge capacity sites were opened in every hospital. So who was redeployed? First of all, our redeployment was voluntary, and we started with our peri-op and our PACU staff because the surgical volume had dropped. So that was really the most logical area to start with. The PACU staff was selected first because they had usually past or recent critical care experience. And we always maintained a skeleton staff in the primary assignment areas. We also redeployed nurse anesthetists, ambulatory nurses, because the clinics were closed. Providers volunteered to work in areas that they don't normally work in, like the ICU. Nurses working in non-patient care areas like quality, and other experienced volunteers from any area. Nobody was turned away if they wanted to help and they could do a job, they found a job for them. So our challenges really became opportunities. We had daily meetings and senior guidance from the Hartford Healthcare Emergency Operations Center. They did an absolutely fantastic job in guiding us and communicating to all of Hartford Healthcare every step of the way. There was certainly more camaraderie and teamwork 24/7 than anyone could ever have imagined. And I still think that we're feeling the effects of that today. And that's one of the good things that probably came out of COVID-19. So as a high level overview of what the things that we developed, we overall process for the rapid deployment of staff, quick template change to allow broad access for documentation in the EMR, rapid cycle EMR and clinical education and competency training for the redeployed staff, disaster response, reduced nursing documentation policy, a deployment of a disaster navigator for nursing, PPE conservation process, deployment of an electronic employee travel and current state of wellness screening application, which we're still using today, and supportive staff for relaxation and well-being, and around-the-clock nourishment involving community response to the bedside heroes. So some of the just high-level redeployment steps that we had. First, we had the identification of the colleagues to be redeployed. The Central Staffing Office, or the CSO, coordinated a list of names. There was collaboration between the operational and our human resources leadership. We identified those areas of need of additional staffing, and the regional operational command centers, the ROC, worked with the senior leadership of the surge when the surge units opened, and they decided which ones were going to open next. Additional access to the EMR was formally requested and granted, and EMR training, clinical training, and competency assessment was completed. Professional development met with nurses to evaluate their skill set gap in the clinical knowledge and competencies. And there was a development of a COVID-19 playbook, Hartford Healthcare nurse redeployment to ICU level of care that you see up in the right-hand corner there. There was communication of colleagues ready for redeployment back to the CSO and the ROC to fill the staffing schedule. So it really was a cycle of things that had to be done. And then it was the ROC and the CSO then found out the nurses that were completed every phase of this, and they were ready for redeployment. So the first thing that came up was access to the EMR. So the redeployed staff, they almost always required some sort of additional EMR access to document in a workplace that was other than their primary role. We didn't have a rapid plan for granting access in place prior to the pandemic. We had a blanket request form, but the command center staff really wasn't used to using it. It's usually our training staff who use something like that. And additionally, it required a lot of detailed information that came out of our HR system on each employee, and the staff that was working in the command centers didn't have access to all of that information. So the individual requests continued to flood into IT security for rapid changes to support the deployment and staffing. And finally, we made a decision at a certain point in time to change the access at the template level. So we didn't have to do it individually for each staff member. Then we started to think about abbreviated education. So first thing that we did was there were additional live classes for the EMR education. We quickly mobilized that, this is something that we had normally in place, but it just didn't seem to be enough. We had difficulty keeping up with the demand of what was needed. Some of the examples of the modules you can see on the screen that we had, like clinical documentation and flow sheets and chart review, and the list goes on, of things that we had to review because people were working in an area that was different than where they normally worked. So the second thing we did to try to alleviate the in-person classes would develop some educational videos collaboratively with our IT education staff and informatics. And then we used our LMS to track the attestations that they took the education. The videos were available from within the learning area in our EMR. Our professional development created fast-track clinical training modules geared to that ICU level of care that was most needed, and they placed them on SharePoint so that everyone had easy access to it. It was a standardized approach, it was easy access, and they had many modules there like agitation management, emergency procedures, hemodynamic monitoring, and the list goes on there. The abbreviated education was from within our EMR. There was a link to the redeployment training, and then there was this pop-up that came up, and they could just click on it depending on what it is that they needed training for, and they could watch all the videos, and then once they were done, they would go into our learning management system and attest that they had completed everything for that particular template. They also developed a tiered staffing model. This was modeled after the Society of Critical Care Medicine Emergency Mass Critical Care Staffing. And one of our informatics analysts, who has many years in ICU education before she came to our department, partnered with professional development and suggested this tiered model and helped them to create that playbook. So the Tier 1 RN basically is someone who had recent ICU experience, and really could hit the ground running and take care of a patient with just a little bit of preceptorship, and then they would be able to operate on their own. The Tier 2 RN needed some sort of a refresher. They had some experience in the last 1 to 3 years in ICU, and they got that refresher with what I described in the past, and eventually they would be able to function independently. And then that Tier 3 RN, because again, we used RNs from all different kind of walks of life, and so they were given the training as best as they could be. Of course, we couldn't make ICU nurses overnight, but they were given tasks that were delegated by the experienced RN to take care of the patients, like giving medications and doing assessments and documentation. So with this approach, it was really very organized, and I think everyone felt that they got the training that they needed to be able to take care of the patients safely. This is just a little algorithm of what the tiered staffing model looked like. And this one is the formalized onboarding process that they finally developed. So some of the lessons learned through this process, we certainly needed swift collaboration between our operational areas and IT, informatics, and education. We really needed to work as a team to get this done. Policy development was necessary for reduced nursing documentation. We didn't have anything like that. So once we decided we were going to use that, we definitely needed a policy first. Deployment of the disaster navigator for nursing documentation was a visual guide for the redeployed staff who were not familiar with the inpatient workspace. So it was a navigator that kind of put in one place exactly what they had to do to take care of the patients so that they didn't have to search around in different flow sheets that they were unfamiliar with. So it really did work out well. Additional access to the EMR was more efficiently handled at that template level instead of trying to do each individual person when they were ready. And the innovative EMR training methods were necessary for the rapid training at the end user's convenience. We developed that redeployment playbook and put it all together for the leaders and staff. In the beginning, we kind of had different documents in different places, and once we put it all together, it was much easier for them to know where to look. Clear and concise communications to the end users, that was absolutely necessary because they were on information overload, and we really tried to only communicate to them when it was necessary and tried to make it as clear as possible. St. Vincent's Medical Center was not yet on our system-wide EMR, and therefore sometimes was not in the communication loop, but they did very well on their own if they weren't. Standardized communication strategy across all regional operational command centers, and the reason for that is that we wanted to make sure that everybody was kind of operating in the same way and asking that centralized staffing office in the same way. The surge plan was fundamental to success. We all, I'm sure, have all of those practice sessions about surging, and now we know why they're so very important. Third-party systems may need to be expanded quickly to operationalize surge areas. We found that out with one of our systems that we use only in our ICU areas, and when we had surge areas that now were going to house other ICU patients, we needed more licenses to be able to use those third-party systems. And lastly, you need to develop a repeatable process to identify and rapidly deploy disaster access and documentation changes, and then revert back to the current state when it's no longer needed.
Okay, all right. Hi, everyone. My name is Linda Ruggiero, and I am the Director for Clinical Informatics in the Hartford region. I'm the newest member of the team, and having just joined Hartford Healthcare in October of 2019 and then going through COVID-19, it has been quite the experience. So today I'm going to be talking about how St. Vincent's manage their PPE to promote staff safety and to conserve our PPE. During our COVID-19 surge at St. Vincent's Medical Center, informatics played an integral role in managing and validating data. We provided communication tools We adjusted COVID orders, and in addition, I served as a team lead for nursing logistics, but I quickly became the conduit between our current EHR and the changes that we were taking on to accommodate all of the changes with orders and documentation and workflows. In addition to the PPE distribution, we worked also coordinating antibody studies for COVID-19 and a lot of our testing sites. So, and I'll discuss some of that during this presentation. So I just wanted to level set a little bit about St. Vincent's Medical Center so that you can get an idea of our location and where we're located. So St. Vincent's Medical Center resides in the city of Bridgeport in Fairfield County. It was founded by the Daughters of Charity in 1903. It has a long history of service to the poor. And there's really an irony about Bridgeport being in Fairfield County, because Fairfield County is one of the richest counties in the whole country. And we reside, it's really called the two Connecticuts, because where you have the richest people living, you have the most impoverished people living also. So it's really quite a paradox. We're considered a teaching hospital, community teaching hospital. There's 475 beds, 3,000 employees, and 700 active providers. The city of Bridgeport, it's very urban and impoverished and culturally diverse, and there's very close living conditions there. There's a lot of homeless people, and I think that contributed to some of our COVID surge that we saw. We're approximately 60 miles from New York, so that puts us in the metro tri-state area. So we were definitely, when COVID first came, that we were near the hot spot, and people drive through our state, so it was hugely impacted. I told you that we were acquired by St. Vincent's, and currently we're planning an upgrade to the EHR to align with Hartford, but we're not on it yet. All right, so St. Vincent's Medical Center, where were we in the surge? So we were considered a hotspot in early spring. Our close proximity, of course, to New York City led us to have the highest number of cases within the state. To date, we had about 19,000 plus cases in Fairfield County. We have 820 persons under investigations, and we've had over 1,100 deaths. We lead the state in the number of COVID cases with about 4,200 cases. So it was quite an event in our small little hospital. We're not so small, but our hospital. Our local emergency command center was enacted in March 9th, 2020, and our admissions peaked April 22nd with 148 in-house patients that were positive for COVID-19. In addition to the 30-bed ICU that had all COVID patients in the beds mainly, there were additional 3 COVID surge ICUs open to a total of a total of 60 ICU beds. And then we had previously converted all of our semi-private rooms to private rooms, and we ended up flipping them back to semi-private rooms to cohort patients with COVID-19 so that we could reserve some rooms for patients that weren't positive. And this is, as Dianna was talking about the central staffing office, this became very important for us because we had doubled the amount of ICU patients. We had a need for respiratory therapists. We had need for screeners. We had needs for people to do screening outside of the screening centers. And the central staffing office and the ambulatory practices in the area, they sent over approximately 100 associates to help backfill. And we were, of course, challenged by that because, as Dianna said, we're on a different EMR. So everything that we did, we had to create homegrown for that fast onboarding for the employees that came from the rest of the Hartford healthcare system. So this is just a visual that you can take a look at to see where the hotspots were in Connecticut. And this is to date from the University of Connecticut. And you can see that in Stamford, Bridgeport, this lower Fairfield County area really had a very high saturation of patients. And if you notice, it comes up the I-95 corridor, I-91, I-84, right up into Hartford. So Connecticut is really a drive-through state, and this really demonstrates how the spread went through the state. Now, we had some really difficult times with our PPE management and allocation. The first issue that we had is that St. Vincent's is not really disconnected from the rest of the Hartford healthcare system. We're not on the same EHR, and we do not have the same supply chain. And then we ran into this confusion that everybody had at the very beginning, where there was a lack of clarity about what was the correct PPE we use, what was the correct room to put the patient in, who should be wearing an N95, how long should they be wearing it. There was differences of opinion from the CDC. There was conflicting information within our own organization. And then we saw that our central distribution was unable to really manage the correct volume of PPE for each minute. They really had no ability to tighten the belt. A nurse manager would call down screaming for supplies, and they would deliver them. Then we would go up to the floors, and we would find supplies hidden in cabinets and, you know, in closets, and we'd have to pull it back out. And probably one of the most disturbing things that happened early on is that we found that there was pilfering of PPE supplies. One night, the GI suite was cleaned out of every single piece of PPE equipment that there was. And it was very sad and disheartening to think that, you know, people would be taking that, and when it really should have gone to somebody who was taking care of someone at the bedside. We also had a dwindling N95 supply. Unfortunately, we had 3,000 masks that were stored in an off-site location in an improper climate. And what happened is it degraded the plastic head straps that go over the N95, so it degraded that material, and we only were getting about one mask out of every box. So we didn't even really start having our surge when we found that our N95 supply was basically useless. And we were at the mercy of the vendors, of our past owners, to send us supplies, and we weren't always the ones in front of the line. So that was really, really difficult. And then there was really a lack of coordination, of consolidation of tasks for the bedside staff to limit the use of PPE and to limit exposure by consolidating tasks. There was a lot of, we became very agile, and there was a lot of adjustments that we made because we just really didn't know what we didn't know. So we took on the issue of the PPE very, very seriously, and we created a communication tool of who, what, where, when, and why of the PPE guide, and centralized distribution to manage the PPE that became known as the PPE depot. So I'm going to talk first about the 5Y PPE guide, and it was created in an effort to reduce confusion. We developed it with the WHO in mind and their recommendations for nurses to be prepared to prevent COVID-19 transmission and to develop innovative practices. There was also close attention paid to the staff fear and anxiety regarding not having enough PPE and the fear of contracting COVID-19. I can't express this enough, that there was real fear and anxiety. We came to learn that not everyone has the same resilience in a crisis, and everyone's reality is different. And it became a joke among the people who were on the emergency management team that you really know who you want in your foxhole when you go through something like COVID-19. So it was a learning experience on all ends. This is an example of our 5W PPE guideline. This is a living document. This was last updated 6/11, but we're in the process of updating it again. We just required all of our staff to wear some kind of eye protection with their face masks. So this has a picture. It describes all of the different types of PPE, what you wear for COVID patients, what you wear for PUI, what you wear for aerosolizing procedures, anybody who was a person under investigation. We did broad, frequent communications regarding proper PPE use, especially at huddles. We developed a daily huddle, a COVID-19 huddle, every day at 8:30 a.m. We gave the opportunity for people to bring up issues, ask questions. We reinforced the use of proper PPE, and it was a very successful huddle to have as we came through the months of March, April, and May. So the next thing that we did is that we centralized the distribution of our PPE. And this is a picture of our cardiac rehab department. In our cardiac rehab department, of course, they weren't having any clients come in. So we took that space, which was located near the lobby, and we took all of the PPE out of every single department in the whole medical center. And we relocated it to cardiac rehab, and we took account of everything that we had, down to the number of, boxes of gloves, the boxes of shoe covers, the boxes of masks, gowns, everything that we had, wipes. And the PPE depot was responsible for allocating all of the PPE and accepting any donations that came from the community, because we were getting donations. It was open from 6 to 8 at night. Now, we had the nursing units, the nurse managers, every day, 4 times a day, and as needed, they would come and they would fill out these forms about what they would need, and then the PPE was delivered 4 times a day. And during the off shift, if there was a need, the house manager would document what they used and provided the PPE to the unit. And everyone had to, if you received it, you had to sign off for it. This form was then put into a data tracker, and this is an example of the data tracker, and this is usage. So we were able to measure the usage by day, how many masks they needed in each area. So how many N95s did you need for your hospitalist? How many did you need for your ICU? How many did you need for your isolation gowns? And then a running grand total of what you actually did use. It's interesting, the coveralls that we gave to the ICU, they sent back to us because they said that they were too hot. They didn't want to use them. So they said, give them to somebody else. So we ended up with a negative on there. This is the days on hand PPE data tracker. So we did that physical count when everything came down there, and then tracked what we had, how many cases, and when things came in, it got added to this tracker so that we knew how many days on hand we had. This became affectionately known as this spreadsheet, the burn rate, and we were able to see, how many N95s we had. And this was probably April 14th, and if you notice, we were down to 1.2 days or 1.1 day. So at times it got pretty scary to say that we were going to run out of N95s. And this helped us to be more agile. It helped us to really manage the use of our PPE and really get down to this kind of granular level. So why was this important? It allowed for stricter management. It allowed for data capture that was necessary to determine the days of PPE on hand. It also allowed us to, we converted our N95 masks when it started getting low. The clinical staff began covering their N95 masks with cloth masks. They got really creative. They started making homemade bouffant caps. We converted to paper to cloth gowns, which was a huge, huge win for the nurses because they were cotton. So they were lighter and they breathed more easily. So when they were going into the patient's room, they didn't feel like they were suffocating with all the PPE on. We discouraged shoe covers outside of the OR. Amazingly enough, everybody wanted shoe covers for some reason. We accepted donations, and despite all the challenges we had, we never ran out of PPE, which is what was a huge, I think, a huge success on our part that we were able to do that. So when there's a nurse around, there's a workaround, right? So these are some of our nurses with their shower caps before we got to the bouffant caps that everybody started making, and basically ran every store in Connecticut out of elastic and fabric. This is one of the signs that was put out in front of the medical center by the community. The community had an overwhelming level of support. And one thing that I need to say about the staff is that at the very beginning, it was very, very, frightful for them and a lot of anxiety. And then there was a turning point where they said, you know what, we're not going to let this beat us. And they went on this whole photo campaign that they were COVID warriors and they were COVID strong. And I love this picture in the middle. This is our ICU staff at night, and they're formed in a circle and they look like a bunch of tough guys. And this is just some of the masks that they wore, so I'm really proud of them. I'm an ex-ICU nurse, so of course I would be. So the importance of correct PPE for the clinical staff. So I mentioned in the beginning that informatics was involved in the logistics and workflow of setting up an antibody study for Hartford Hospital that they're conducting. They're still conducting the study, and the results are preliminary. But having the right PPE, proper hand hygiene, physical distancing, and consolidation of tasks, we know that that decreases the potential for exposure to COVID-19 and contracting COVID-19. And what we found in Dr. Pavlos Papa's study is that the risk is real, that direct caregivers of patients with COVID-19 are at higher risk to contract COVID-19. And a preliminary data that we're seeing, 7,000 employees in the Hartford Healthcare seroprevalence SARS-CoV-2 study showed an 8% antibody conversion rate for the direct caregivers, and that was twice as high as those employees that did not have any direct contact with exposed patients. So having that right PPE, conserving the PPE, is one of the most important things, in addition to decreasing the amount of time that the nurses and the bedside caregivers stay with the patient and coming up with different opportunities to help that. So what are the lessons learned for St. Vincent's? Well, personally for me, I can't get on the Hartford Healthcare EMR fast enough. That really was a very stressful point for me. And to communicate, can't say that enough, is that especially with, rumors and fears, you just need to take that into consideration. And I think another thing is that, we were talking about this in healthcare for years before it happened, that there was going to be a pandemic. And really not a lot of attention was paid to maintaining adequate supplies of PPE. And we really need to do that. We need to maintain adequate levels at all times to support a pandemic. And as we learn, that it needs to be properly stored. If it's not properly stored, then it's not going to do anything for you when you really need it. And one of my biggest takeaways, rounding in the hospital and being there during the COVID surge is that, encouraging conservation of PPE, but then understanding the fears and the perceived reality of the staff and what they're going for. And lastly, of course, the risk of contracting at the bedside is significant, and all measures should be considered to reduce exposure time to patients and adequate PPE. I just wanted to give credit to Dr. Papalas and his team that are still working on the antibody study. This came from the University of Texas, and some great things about nursing ingenuity during COVID-19. Our state of Connecticut public health data. I have to give a lot of credit and a big thank you to my fellow co-worker, Tiffany Rodriguez, who's the Director of Special Projects, who really managed the PPE depot at St. Vincent's and had an integral part in that. And she shared her information with me so that I could share it with you today. And then the University of COVID case report here. Thank you.
So thank you so much for your time. I think we're going to go to our question time now. Mary?
Well, that was just a fabulous presentation. It was really, really wonderful. I have to applaud. Let's see if I can get my little reaction here. We have to applaud everybody doing such a great job. So a couple of questions to the team. Who was in your command center?
So it was a combination of, they really took pretty much anybody that would go in there. Managers and directors were in the command centers, and it was, clinical ones, it was HR, it was some of our executive management team would be there, transport directors, the housekeeping directors, everybody that had anything to do with patient movement and getting supplies and staff to where it was needed was part of those command centers.
Great. Would you be willing to share a copy of your disaster navigator?
I could share a copy of the components of the disaster navigator, yes.
Okay, that'll be great. I think that a few people would like that. That came for the Mass General Brigham. Can you share any details about how you decrease documentation?
Mm-hmm. When I saw that, I was like, oh boy, I have to try and remember that one. So I think some of the things that we did was we adjusted some of our required documentation rules. We didn't remove required documentation, but adjusted some of the rules, the timing rules, and some of our best practice advisory, our decision supports that we usually fired to the nurses. We kind of laid back on a few of those. And also our care plan outcome summary notes that we used to do once a shift, we did once a day instead. So those are some of the examples.
Have you re-implemented them?
Yes, that's the last bullet that I had on my slide is we had to have a way of knowing how to turn these things off quickly and how to put them back. And then have a consensus from all of the CNOs that it's time to put them back. And that's what we actually did. We had meetings with them and said, okay, this is what we did. They approved what we were going to do to reduce it. And then we had to meet with them to decide when to turn it all back on again.
Great. I was really impressed with your different staging or layering of nursing expertise. Mm-hmm. I just would like some anecdotes. How did that work? Was that difficult, or it was very impressive, and I can imagine implementing it had to be even more challenging.
I know hearing from so we all kind of have a home base, and then I'm in the central region, and I know hearing from the central region, it was the ICU nurses that really needed the help with their patients couldn't have been more grateful for any help that they got from anybody who had training as a nurse. So I think that it just added structure to what it was, the education that was done. And it made the nurses that were being redeployed have a feeling, that they had some kind of background and review and education as to where they were going. I mean, I also think when they knew about the tiering and they knew what category that nurse was coming from, the nurses in the ICU then understood the responsibilities of that person and what they could do. So all in all, I think it worked out very well.
I want to add another piece to that too, because in hindsight, one of the things that we're going to pilot probably in one of our smaller hospitals is remote ICU nurse. Not because we want them to work from a remote position at this point, even though I know that's a great example as well, but we would like to have expert ICU nurses looking out over novice nurses or nurses in this situation who might have come from outside an ICU and are trying to deal with practice issues or managing a ventilator or whatever. And how can we do that and support using that level of expertise? And certainly we're considering nurses who are also now thinking, am I going to be able to make it? How much longer am I going to be able to do this with this level of physical and safety problems when I'm, aging, that type of thing. So we're really looking forward to that type of a different type of care model.
Well, that's really interesting. That's really interesting. Any update about managing recovered patients who had COVID and are recovering? Any specific demands or considerations?
This is Michelle. I'll just say that I know I'm involved in the research studies and the data gathering that people have requested. And that is a big unknown area, trying to figure out exactly the depth and breadth of the people with comorbidities and how they will do after a COVID diagnosis. So that's not really an answer, but I don't know that anybody has an answer.
Sure, that's a good answer. Linda, that was very impressive about your drive-through. We're in Rhode Island, so I'm glad that they went north on your map. But that was very impressive. Talk about data visualization. There was one question: which EIHRs are St. Vincent and Hartford Healthcare using?
We're currently using Cerner, and Hartford uses Epic.
Great. Did the PPE depot manager reuse any of the PPE? And specifically, what was your practice for reusing N95 and face shields?
So as far as repurposing N95s and cleaning them, I know that some people, some hospitals did send out and do the aerosolization cleansing of them, but we never got to that point where we had to do that. We were investigating that if we would need to do that, but we never got to that point. As far as reusing the PPE in the on the floors and in the units, each nurse was given an N95 mask and expected that if she took it off or he took it off, that they would put it into a brown paper bag. They were all over the unit, and they would have to put a hash mark because they could only wear them 5 times. So they wore their mask primarily for the whole shift. And most of the people only took the mask off to, you know, have their lunch or get something to drink. So the N95 could potentially last them a couple of days. We found it was mainly about 2 days that they would last. So it was just a way to conserve it. And if somebody wanted a new one every day, we didn't deny them that. And then, of course, if anything was visibly soiled, or if they had a patient who had varicella or TB, then they would dispose of those.
Great.
And as far as the face shield, everyone was issued a face shield. It was your face shield, and you better take care of it and use it. And that was it. You got one face shield. And there were some people that lost their face shields, left them in the car. We had some extras, but the expectation was that you had to take care of that piece of equipment because it was a lifesaver.
Great, thank you very much. I think that's all the questions. I do have a comment from Michelle. I love that you put your model into a Maslow hierarchy of needs. I thought that's very, can a nursing model be far behind? I like that very much. So I'll open it up to the group to see if there's any other questions. We might have one more, but any other questions if people want to, oh, could you share who is on your data analytics team? What type of people, and I guess what kind of skill sets?
I was kind of the main person from clinical informatics, but everybody participated in that because I've been with Hartford Healthcare for only 2 years and rely on everybody on the team who's certified in all the other areas. So I was including them and, you know, asking questions throughout, and, you know, as orders changed, COVID orders, isolation orders, things like that, we all need to stay in great communication. And then outside of that, it was really our developers, and we have a visual analytics team, and we actually also brought in consultants who, we didn't bring them in for this, they were already here working on a different project, but we quickly asked them to assist with the Tableau dashboards because it was a huge undertaking. But really, you know, I was probably the point person for clinical informatics, but we all participated and contributed.
Michelle got up every day, 5:30, to make sure that some of the components of those dashboards were ready for the day to begin. And, you know, she's just an amazing individual, and we thank her.
I have 2 quick questions. So I'm just curious, was Tableau hard to use, hard to learn? And as another question, it sounds like, you know, you have multiple hospitals within your healthcare system. Were there data governance issues, or was it easy? All the data came out clean and you didn't have to think about it?
Oh, it was just easy, and then we ate bonbons and we braided each other's hair. No, it wasn't that.
That's why your hair is short.
No, that was where the data validation was a really big struggle, and we had people who wanted the data now. They were really insistent, but especially with the way the orders, we had those miscellaneous, the viral PCRs, then the COVID orders, and trying to get those. And then we had a bunch of performing labs because we were enlisting help from a lot. That validation of that took many, many hours. It did not come out right the first time. It really highlighted the importance of the relationship between clinical informatics and the technical side in order to produce really reliable, credible information. Tableau is not hard to use for an end user. It's really quite simple. I have a developer license, but most people wouldn't. But I did have that, so I was able to contribute, but it wouldn't have been necessary. It's just that I happened to know how to do it. The technical team took care of that. They took feedback, but the end users really liked it. It was intuitive and quite simple to learn. So
Great. Anybody else have any additional questions? Yes?
Mary, I just wanted to mention that from St. Vincent's perspective, as being the new kid on the block, getting data to Hartford Healthcare Center in a disparate EHR was quite a challenge. And we had to basically marry up data fields that didn't exist in our system. So we had to basically create a kind of like a key to get the data to Hartford, to the tableaus that, you know, Michelle was working on with her team, so that we would align with everyone. And it was really quite a task to do that. And when we finally got it finished, we FTP everything over to them, and then it would fold into the Tableau dashboards miraculously. And there we could see all of St. Vincent's data. And for me, that was really amazing, because we felt like we were then really part of the system. So it was a great effort on everyone's part.
Even my dog liked that response. Did IT port all the data into the database for Tableau, or just curious about the logistics?
we actually go right into Epic servers. There's a server that is available for all of that information. And then, as Linda said, the St. Vincent's group, we would get their data and receive that in and display that. So Tableau can receive information from multiple sources. So we had the two EMRs that were contributing data.
Well,
Hey, Mary,
yes.
I'm not sure if you saw Sandy's question about documentation reduction during COVID. Did you see that?
About the
Oh, okay. I'm sorry. I missed that.
No worries. That was good. I like that. I know we had a whole presentation on reducing documentation, and it was interesting because everybody was in consensus that that's the easiest deployment of all. You tell people not to do things versus doing things. Any other questions? Well, on behalf of NENIC, I'd really like to thank everybody for showing up tonight, and especially to Hartford Healthcare for the tremendous amount of work and energy you put into this presentation. It was very professional, very informative, and it was really an honor. We're trying to be true blue to our New England part of NENIC, really trying to branch out. And with all the new technology, it's really, I think we're meeting that goal.
It's truly an honor to be in nursing informatics these days, because really the talent and the focus and what we can do to support safety, our staff, our organizations is just really amazing.
We've come a long way, haven't we? It's just amazing. And skill sets. I mean, we're right in the beginning, but it's just amazing where it's come and where it's going to. It's really amazing. And the final little plug is check out our website, because there are some upcoming programs, both at New England HIMSS and of course our member highlights, and the awarding of our very special and prestigious Rita Dieselsdorf Nursing Informatics Leadership Award, which will happen at our October program, and we're really excited about that. So on our behalf of NENIC, thank you and good night.